I think we still struggle to control some of our patients who have refractory hormonal syndromes with our current therapies, and so an unmet need is to further help improve our patients' quality of life as they live with these cancers. Another unmet need is really trying to personalize our therapy. We have a number of treatments that can be helpful, but sometimes they are not for each individual patient, and trying to come up with predictors of benefit to various therapies to more closely match or better predict what patients will respond to which therapy is another unmet need, rather than treating everybody in a similar fashion. I think we also need to increase the recognition that these patients need to be cared for at expert centers with multidisciplinary expertise in the care of these patients, which can also facilitate better enrollment to clinical trials, which can advance the science and advance the care for these patients.
I think there are a lot of unmet needs still. One is simply learning how to best tailor the current treatments that we have, learn how to sequence them, and maybe even better, more importantly, learn how to predict which patient will respond to which treatment. That's going to be a real challenge as we develop more and more treatments for this disease. But beyond that, I think we need treatments that work better and that have a better therapeutic index. Some of the treatments that we have still have a lot of toxicities. They have a negative impact on quality of life. And quality of life is particularly important in patients with slow-growing tumors, patients who have a relatively good life expectancy. We really need to develop treatments that are less toxic and less risky. The acute need, though, is perhaps greatest for poorly differentiated neuroendocrine carcinomas. We really haven't moved beyond first-line platinum etoposide there, and these are really aggressive tumors, and we need to develop new treatments. It could be that immunotherapy, the checkpoint inhibitors, work better in that population than in well-differentiated neuroendocrine tumors. So I'm happy to say that there's a large number of new studies that really, for the first time, are targeting the poorly differentiated neuroendocrine carcinoma population.
The unmet needs in neuroendocrine tumors are a few. Number one, I think for poorly differentiated high-grade tumors, we don't have a lot of options. We have our first line, and after that is almost like dealer's choice. Different oncologists choose different things using a small cell lung cancer algorithm. So we definitely need more trials and more options for poorly differentiated high-grade tumors. In the low-grade neuroendocrine tumors, I think we'll have to decide where PRRT will play a role in terms of timing of treatment. I also believe that we need more options for mid-gut tumors. For pancreatic tumors, now we have several lines of treatments, but that's not the same for mid-gut. And we also don't have an established role in the neoadjuvant setting for any treatments or the adjuvant setting for patients that have been completely resected. These are all unmet needs, and there is plenty of work that we can do.
The next research questions are how to sequence treatments for neuroendocrine tumor patients. There's a number of trials that have started accruing patients. The COMPETE study is looking at lutetium dotatalk, a slightly different radiolabeled somatostatin analog from lutetium dotatate compared to everolimus in non-functioning enteropancreatic neuroendocrine tumors. The Sequitur study is looking at 5-FU streptozocin, a chemo regimen, versus everolimus in pancreatic neuroendocrine tumors. And there are other studies comparing active regimens. That's a very important development.